Welcome to the Jaros Health Podcast, where we make it easy for you to better serve older adults. This is the weekly Jerry on Ice segment that is a collaboration with the Institute of Clinical Excellence, the official Con Ed provider for the Jaros community.
Hello, everybody, and welcome to the Wednesday edition or the Jerry on Ice edition of the PT Daily Show. I am Christina Previtt. I am one of the two lead faculty for the Modern Management of the Older Adult Division. We are right in the middle of our online cohort. We are starting week 5 of 8. And so if you want to jump into our next online cohort, it is starting in September. In terms of, good morning, Kelsey, where we are, we will be in Camarillo, California, August 24th. And then we are in Torrington and Minnesota. We have a whole bunch of courses coming up in the fall. I should probably know where I'm going. So if you guys are interested or we're around your area, I would really encourage you to come and check us out. It's a really fun course, and it's 16 hours, a bunch of CEUs, and it's just a good time had by all. Okay, so for today, I thought that we would talk a little bit about exercise prescription for arthritis. So there's a lot of research on, especially lower extremity arthritis, around, the fact that one, exercise is beneficial, but two, weight management can be a really important way for us to manage symptoms and pain from arthritis. And 3 is that as much as we think that osteoarthritis in particular is wear and tear, there's definitely a systemic inflammation effect that is going on even with osteoarthritis. So CRP can be elevated for individuals with wear and tear types of arthritis. And the term arthritis is really a constellation of syndromes or conditions in which there is destruction of a joint as part of the pathological process. So there's actually 30 different types of arthritis. So we see a lot of individuals who are experiencing joint pain. And so as physiotherapists, this is probably one that's focusing in the geriatric population, one that I'm seeing a lot of. And so when I talk to clients, so I own a physiotherapy gym hybrid, and we do group exercise programs for individuals with arthritis. So those who are trying to conservatively manage pain from arthritis, are trying to be as strong as possible, awaiting a joint replacement. In Canada, because of our public system, we can have sometimes a 6-month to 8-month wait list to get a joint replacement because of our resources and the way that our system works. Or we have individuals who are trying to maintain strength and function after joint replacement. And so we're seeing a lot of these individuals, and they're being told that they need to exercise, and that's a great recommendation. But what often happens is that individuals will go into a gym, they will go into a boot camp, they will go into an aerobic program, something that their body isn't necessarily ready for, and they'll experience joint pain for several days afterwards. And so nothing is going to get you to lose motivation for starting an exercise program that you probably already feel a little bit self-conscious or worried about in the first place than going to a class and all of a sudden having this huge flare-up in pain, and eventually you just trickle off and you don't do a lot of the exercises that you should be doing. So as usual, I have my notes on the side. So when we're thinking about our exercise prescription for arthritis, we have to consider what our clients are doing, how they are doing it, and how much they are doing. And so those 3 things are key variables in any strength and conditioning program. So essentially, we're talking about specificity, biomechanics, and volume and recovery. So we're simplifying it when we're talking to our clients, but those are those 3 key variables that we're going to be considering when we are starting to prescribe exercise programs. And I think the more the PTs can get involved in not just TheraX, like not just therapeutic exercise, but trying to put individuals on a full exercise program, including aerobic conditioning, helping them when they go into the gym, when there's all these machines and all these dumbbells and all of these options and these people who are doing things that might be almost a little intimidating to get into. If you have them set up on a program and they know exactly what to do, how to do it, what range of motion is going to be applicable for their joints, then we're going to see, I think, a really good response from that. So when we're talking about what individuals are doing, I always ask my clients what type of sport, activity, exercise that they enjoy doing. So we have research in arthritis around different modalities, like, for example, swimming can be really beneficial for somebody with arthritis, especially if you have a warm therapy pool. I personally hate going into the water, especially in a Canadian winter. So if you tell me that I need to swim and I hate it, then I'm not gonna do it probably. I might do it once or twice because, I respect my PT and I want to listen to what they're saying, but that's probably not gonna be a good long-term strategy. So if I'm asking them what they're doing, then I'm also going to bring the exercises that I select from a strengthening perspective back to adhere to that principle of specificity to ensure that I'm getting the biggest buy-in, hopefully, from the client that I'm working with. So if we know that, for example, somebody likes walking, then we can start modifying different variables to hopefully reduce joint pain and allow them to continue participating in their activity. So that's going to be the best way to get an individual to buy into a program. And so some of the things that we're going to need to consider are impact of the activity. We know that individuals with arthritis are not going to tolerate higher impact sports as they will for low impact sports. So is there a way that we can modify the impact of the exercise that they're already doing? Terrain, can we modify where they are doing it? I don't know if you guys, I think you guys have Costco or Sam's Club down in the US, but a lot of my clients, because of the polished, what's the polished cement that is on the floor in Costco, a lot of my clients with arthritis say that that's probably the worst activity that they do. So is there any way that we can get individuals, and if their gym is like that, then they're probably going to be experiencing more joint pain with standing-based exercises than if they were on a softer terrain. So could we change the terrain in which they're doing things to try and reduce joint impact while getting them to continue to participate in the exercise program of their choice? Weather is going to obviously play a role. I've looked into the literature on weather patterns and arthritis, and there doesn't seem to be a very clear relationship. But if I talk to any of my clients, they're going to tell me that when it starts getting cold or rainy, that all of a sudden their joints are going to stiffen up and they're going to feel a little bit more pain or irritation in their arthritic joints. So if we have an individual who really enjoys doing things outside, we're going to have to consider warm-up routines for individuals who are going to be walking outdoors. So in terms of what they're doing, we're thinking impact, terrain, weather, experience or routine, and then allowing ourselves to consider what the demands of those activities are. And that could just be gardening, right? So if someone has to get onto their knees in order to garden, then that's going to be something that we're going to be considering as variables when we're thinking about specificity of exercise prescription for individuals with arthritis. So then we get an idea of what it is that our clients want to do. We try and figure out ways that they can be doing the exercise routine or sport or activity that they're doing already, but trying to do it in a way that's going to mitigate flare-ups in joint pain. From there, we're going to try and support their activity or encourage new activities that they may enjoy by starting with more of a therapeutic style exercise program. So that's where we go in from what you do to how you do it. So this is where the strength and conditioning coach would come in with an athlete and start teaching proper form and proper biomechanics. As a physical therapist who's working with individuals who are older, who have sometimes a whole laundry list of different issues going on, whether it be medical issues or orthopedic issues, this is where I have to put on not only my strength and conditioning hat, but my PT clinical hat to make sure that I am not going into ranges of motion or pushing through different issues that may flare up joint pain. So when we're thinking about how we are doing it, the one thing that we can do, Jeff Moore talks a lot about building the bike, is that we can start evaluating different functional tasks. So one of the easiest things to think about is the squat. So individuals often with arthritis in their knees, when I tell them to squat, they look at me very apprehensively. They don't like squatting. It hurts, but I tell them, you have to get up off of a toilet seat. So we have to at least figure out a way for you to be, exercising so that we can make it so that you don't have a lot of pain and discomfort, and it's really awkward to get up off of a toilet. But what can happen is I can ask people to squat and they can come on their toes. They have that femur that impacts into that patella. They start experiencing anterior knee pain because they're not in a proper proper alignment, an optimal alignment for them. It may not obviously be perfect. So the first thing that I'm going to do as a coach is I'm going to be if a squat is a specific exercise that's going to support their activities, then I'm going to choose that. And secondly, I'm going to figure out from a prescription perspective, at what range of motion are they starting to experience pain? I'm going to try and clean up their movement pattern. So if they're starting to really go onto their toes early, then I'm going to try and get them to shift their weight back. I'm going to try and, spread out their feet further apart if that's an issue. I'm going to try and turn their feet out in different ways. Maybe they've been told that their toes have to be absolutely straight when they're squatting, when we know that is not true. You can have anywhere from 0 to 30 degrees of external rotation as long as your knee is properly tracking over the foot. So, I'm going to start playing around with stance. And oftentimes I can get buy-in just from that, because something that was painful when they came in for the assessment, we've done a little bit of adjusting, and all of a sudden now they're not experiencing any pain and they're able to complete that movement with relatively little discomfort. So if that's the case, then I'm going to find what height can I use to start strengthening through range of motion before I start to experiencing joint symptoms. And completely pain-free may not be my goal. So I'm thinking, especially for individuals who have had arthritis for long periods of time, sometimes I'm going to be able to have the exercise selection have zero pain associated with it, but sometimes it is going to cause a little bit of discomfort, and sometimes that can be okay. If we have somebody who's severely deconditioned, then any sort of activation of the muscles of the lower extremity may cause discomfort. So I conceptualize that. I say, how much discomfort is that? Is the pain sharp or dull? Is it increasing through the set? Does it go away as soon as we stop exercising? And if it's relatively low and dull and it stops as soon as we are done with the set, then usually I'm like, okay, we're gonna get there. But then I educate and say, if it starts to increase, if you start experiencing sharp joint pain, if you're starting to feel like the pain isn't subsiding relatively quickly once we stop exercising, then that probably means that we are pushing it a little bit too hard for today. And so if I can do that, then I'm able to find a range of motion that allows individuals to continue strengthening their knees. Obviously, we want to try and get them as big in their range of motion, as optimal into their range of motion as possible. But at the very beginning, that may not be realistic. That may not be something that we're looking at. And it could be something that we progress to over time. And so if we're looking at range of motion, that's another way where we can get people, if you have a high-low bed in the clinic, if you're in home health and you have, different chairs in a person's home, you can try different ones and see where they are, having little symptoms, and then we'll start to progress there. The other thing is to try and change impact strategy. So for example, some of my individuals who are working with a CrossFit athlete, we're going to start seeing masters CrossFit athletes. And one of the exercises that they do often is box jumps. So if you are seeing a person who is competing and box jumps is part of their program, well, then we're probably just going to have to make sure that they're not rebounding, because highest impact is rebounding box jumps. So you're jumping up, jumping down, and jumping right back up. If people are starting to experience arthritis-like joint pain, then that second rebound we can probably eliminate, and then we're reducing impact on the joint by 50%. If we have individuals who are not really interested in competing and are just using CrossFit as a modality to stay healthy, then we can start changing things to step-ups. We can start changing the height of the box in order to reduce the impact going through the knee. For my individuals who are more deconditioned, who aren't in a CrossFit gym, and I'm using things like step-ups, I want to try and make sure that I'm at least at 6 inches so that I can make sure that people are able to ambulate around a community with any variability of step height, because we're very unlikely to see a step that is more than 6 inches in height. So, modifying range of motion, modifying impact, and then looking at volume. So what you're doing, how much you're doing, and how much. So how you do it and how much you do. So how much you do is looking at volume. So this is where we're looking at prescription for sets, reps, rest, prescription of times per week. How often do we do a home exercise program where we're saying that we want individuals to do an exercise every single day? If I'm doing a progressive exercise program where I'm expecting individuals to have a little bit of soreness, I am not telling my client who is in their 60s that I want them to do these heavy squats every day. I'm telling them I want you to do them every other day. If you're experiencing a significant amount of soreness, and I'm educating on delayed onset muscle soreness, if we are, starting to experience those symptoms, take a day off. That's very normal. It means that the muscles in the front and backs of your legs are getting stronger, and you just need to give them a little bit of time to recover. You're going to do this aerobic exercise instead, and I'm going to give them another option for still continuing to be active that day, but probably not applying progressive overload, and then giving them strategies to work through that. Because if I'm trying to think like a strength and conditioning coach, I'm not going to be heavy loading somebody, especially somebody who is potentially very sensitive to impact and volume. I'm not going to be loading them the same way every single day. So just things to think about. And so then over time, the other thing that we want to be considering as, conceptualizing arthritis like strength and conditioning is that people are going to improve over time in terms of strength. Even if we're still experiencing low-grade joint irritability, sometimes what we're going to see is that strength is going to improve much faster than pain is going to decrease. If individuals have been experiencing pain from arthritis for, 5-6 years, they may not have this instantaneous change. We're not going to see a change in strength in a week, and that means that we may not see a change in pain patterns over a week. But we can start to, highlight the awesome list that Dustin has talked about, where we're saying, when you first came in, even if we did like a 30-second sit to stand test, for example, if we did that, then we retest them, 2 weeks later, they're probably going to see an improvement in that, even if they're potentially feeling a little bit irritated that they're still experiencing joint pain. And so the way that we have to consider and conceptualize is that we need to be progressing. We also need to be de-seeing exercise programs that are now too easy. This is where, we kind of harp on the ankle pump, but oftentimes that's given very early on in an exercise program, especially after an acute episode or if somebody's in the hospital, but we never discharge any of our exercises. So I will say to my clients, okay, I want you to replace that exercise with this exercise. And that may be for especially some of my older clients, crossing out an exercise on their program, especially if they want it listed out, and adding another one on the bottom. Because as people are starting to get fitter, as they're getting stronger, we need to be challenging their system in different ways, which may mean that exercises that were appropriate at the beginning of their program are not going to be appropriate at the end. So just ways that we're going to consider. So if we're thinking about this big picture, in terms of how we're going to start doing exercise prescription for arthritis, we need to start thinking above and beyond therapeutic exercise. So we have, the exercises that we're doing in session, but can we start developing exercise programs so that individuals can develop autonomy and a sense of having the control to go into a gym and be able to exercise in a way that is not going to flare up their joints, but is going to be very holistic and is not only thinking that we're going to try and train VMO or gastroc or whatever. We're going to start training them as potentially somebody who is looking to start in a sport or what have you, whatever their goal may be, and start to also think about their activities. So we may be doing strengthening for an arthritic joint, but what about cardio? Can we give them different parameters for doing that on other days? How can we really conceptualize this into a gym program that has therapeutic exercise as a component? And so I hope you guys found that helpful. So breaking it down into, what you are doing, what is the activities that individuals enjoy? What are the things that they want to get back to or they want to continue to be able to pursue, whether that be sport or gardening or walking up to the mailbox that happens to be 500 feet away? How are you doing it? Are we evaluating biomechanics? Can we do any shifts in the way that people are moving in order to see a pretty strong within session change in pain and irritability? Can we modify range of motion? And then how much are we doing? Are we evaluating volume, sets, reps? Are we using recovery in between sets in a very strategic way? And are we evaluating this change over time? This volume is not going to be that they're experiencing day one that they are able to tolerate is not going to be the same on week 3, where they're going to be able to tolerate more. And are we progressing that? And then from a secondary piece to that, are we discharging exercises? Just like, we get annoyed when people don't lift a weight restriction. And so individuals are coming 10 years after a cardiac surgery and saying that they can't lift more than 10 pounds. We have to be accountable to ourselves as well and say, are we discharging exercises that are no longer necessary, or not that they're no longer necessary, but that they're too simple and that we have something that's more challenging that we want to be focusing on. So we need to be modifying volume, trying to think about it in a conceptualization of a holistic exercise program where we're allowing exercise prescription to be guided by pain points, and that we are changing these pain points over time. Thanks, Avery and Colleen. That's very nice of you. I'm seeing this come up. I hope you guys enjoyed this episode. If you guys have any other questions, comments, things that you want to discuss when it comes to strength and conditioning and arthritis, post them in the comments below. I hope you guys are enjoying this beautiful weather. If it's beautiful where you are, it is gorgeous where I am, and it's the middle of the summer, and there's definitely nothing that I can complain about in terms of the weather. So I hope you guys are having a wonderful Wednesday, and I will see you all in a couple of weeks. Bye.
Thank you for listening to the weekly Jerry on Ice segment of the Jaros Health Podcast. If you found this episode helpful, you should go to jaroshealth.com to check out our course offerings that will make it easy for you to better serve older adults. Once again, that's GEROS health.com and click on the courses tab. Thanks for listening.